Hello, my name is Dustin, and I'll be discussing Marfan syndrome. I chose this out of the genetic disorders. The other ones were coronary artery disease, like the BRCA1, BRCA2, cancer expression genes, and major depressive disorder. There's a guy named Robert Wadlow who was born in Illinois who's 8 foot 11 inches tall. I figured he would have this syndrome because one of the characteristics is a tall, thin body, depicted by my really great drawing here. But it turns out that he just had a overactive hormone production of growth hormone, and that's why he was super tall. Marfan syndrome is a genetic disorder that affects the connective tissue, specifically the FBN1 gene on chromosome 15 changes the fibrillin 1 protein, and this makes connective tissue less strong and leads to a lot of symptoms. The penetrance for Marfan syndrome is 100%, so it will be expressed if you have the gene. The expressivity, though, is variable, meaning you might have light to extreme symptoms over time. It is autosomal dominant, which means that you only need one of the genes to be expressed. When people have Marfan syndrome and they want to have kids, they are encouraged to get genetic counseling to see what the risks are for future offspring. If we look at the symptoms, again, you have a tall, thin body. There is characteristically 1 in 10,000 people have this. You also don't see any ethnic, racial, or gender preference for Marfan's syndrome. So I put a couple of the symptoms on the diagram. So we have the nearsightedness, so they might need glasses. They could have scoliosis, so their spine could be curved, which may or may not lead to surgery. Arachnodactyly is where you have elongated extremities and fingers. So arachno is, for the spider. You can have increased ability to have spontaneous pneumothoraxes, so your lung will just collapse out of nowhere. Physically, you can see stretch marks on a patient, and there's no major indicator like weight loss or pregnancy on why these people develop these stretch marks. One doctor I listened to talked about how a lot of these physical characteristics are what they look for to diagnose Marfan syndrome. So instead of doing like a test and saying, oh yeah, you have this genetic variation, they just see the symptoms first, and that is the primary way they diagnose for this syndrome. Here's some other symptoms. We have aortic dilation, which can lead to aortic aneurysm. This is probably the biggest issue for Marfan syndrome patients. If your aortic dilates and you get that pocket and the tissue is just swelling and swelling, eventually it might rupture, and that will be a medical emergency. Remember that the left ventricle pumps oxygenated blood to the rest of the body through the aorta, so that's a critical pathway for us to monitor. They can also have mitral valve prolapse or just regurgitation on the valves. They can have joint hypermobility. So basically this just means like they could take their fingers and move them way further than the average person. I did read also online that one person who has Marfan syndrome really enjoys it because they can play basketball a lot better. They're a lot able to run around doing that. You can also be flat-footed. The next two are pectus excavatum and pectus carnitum. That just means your chest is protruding in and then protruding out. You can also have ectopia lentis, which is where your eye lens dislocates. So again, another eye issue. This is usually seen in younger patients, and this can be a major indicator that you have Marfan syndrome, and you have to do surgery for that. You can have enlarged ribs and a large spine, also has other issues. Interesting, going back to the autosomal dominant, about 25% of Marfan syndrome is actually just a random genetic mutation. So it can just form. If we look at our treatment options, since there's no way to actually diagnose, there's no cure for Marfan syndrome, but we have treatments like the echo. We again want to look at the heart. We can look at the aorta and the valves and just the overall heart function to see how the patient's doing. They could do a yearly echo to measure the aortic dilation that's occurring. Some patients who aorta dilates too far, they can go to like prophylactically, sorry, I can't talk, surgery to help repair the aorta. That way it doesn't rupture. Preemptively, before you have heart issues, maybe we can put you on a beta blocker or ARB to help decrease heart stress and decrease that dilation. You might also need to have spinal surgery or eye surgery, depending on how bad that is. Again, the variability or expressivity is variable.